So, as said, I'm a cardiothoracic surgeon. I do heart surgery and I do lung surgery. I've got a particular interest in both. There are often, some surgeons do thoracic surgery, some do cardiac, and there are a few subset like me who do both. So we're going to talk about some of the surgical aspects of mesothelioma. I guess the sort of the preamble, the thing I sort of wanted to talk about first up is that in general, what we think about as surgeons when we are thinking about surgery for cancer of any kind. And the thing is that, the reason why cancer is bad for us in the first place is that cancer is an abnormal growth. An abnormal growth starts with one cell. We all have different, we all start out as one cell, and then we grow. And then our cells become mature. So we have cells that form our eyes and cells that form our muscles and cells that form our skin. And they stay that way. They have their role in life. And they refresh themselves. We get new skin, we get new hair, we get new nails. We're not made of the same cells that we had when we were first born. But what happens with cancer is that if a cell deviates from that role, actually, if the cell gets the ability to actually grow beyond its purpose in life, if that cell then starts to take over what it's next to, it starts to grow, it starts to split itself and reproduce itself and then grow into the tissues it's next to. And then if it gets the ability to then spread from where it's supposed to be to actually other parts of the body, it starts to consume the body's resources and everything and take over other parts of the body. And that's what cancer does. And that's why cancer is life-threatening, because it takes over our whole body beyond what it's supposed to be. So when we're thinking about what we can do as surgeons for cancer, what we're looking at is we've detected that there are some cells which are abnormal. They've got this ability to grow beyond where they're supposed to be, ability to spread to the rest of the body. And we're trying to think about ways we can actually cut that out and stop it from doing that, from spreading to the rest of the body. So we have an idea of where the cells are. We have an idea of where the cancer is. We try and cut out around the edges of that. And we know there's a pattern. We kind of know where it's going to go to next. So we try and cut down to where it's going to go to next and try and get ahead of it. Because all of the scans we have, the CT scans that Dr. Bowler showed, and I'm sure you've all seen CT scans and X-rays and PET scans, they're all very good at detecting cancer, but only down to a certain size. It can't detect cancer of one cell. And often we're talking about, if you've got a 1 millimeter ball of cancer somewhere, you can't find that on a scan, because the scan can only see down to, with enough certainty, down to about 5 millimeters or around that size. 3 or 4 millimeters, you might be confident, but around 5 millimeters is roughly where we say. And so what we have the limits to what our scans can tell us. So we have to then work with that. So we can't 100% guarantee that every bit of, that we know where every little bit of cancer is hiding. We know where the larger lumps of it are. And so when we're planning surgery, we're trying to cut out where we know it is. We try to then give it space, because we think that there's probably going to be little bits of it growing around into the tissues around it. And then we know where it's going to go to next, so then we cut down to that. So specifically in lung cancer, just to use that, often we get asked the question of how come you can cut out a lung cancer but you can't cut out a mesothelioma? So lung cancer is cancer growing in the lung. If we detect it when it's early, we know that it's in the tissue of the lung, in a certain section, in a lobe of the lung, and that we know that if we leave it alone, what will happen is it'll go from the lobe down to the root of the lung, down to the glands, the lymph nodes in the middle of the chest, and then it will spread to the rest of the body. So with surgery, if we can cut out that lobe down to the root of the lung, we can cut out the glands in the middle of the lung, then we know we're kind of trying to get ahead of it. We know where it is now, we know where it might be next, and we try and get ahead of it. Then we have a good chance of actually clearing it all out. And the problem with mesothelioma is where mesothelioma occurs. And that is that it grows on the pleura, which is the lining inside the ribs. There isn't much outside that. So if mesothelioma is growing in the pleura, it grows into the muscle next, it grows into the ribs next to it, and simply you can't get around the edges of it. And this is what we try to do with some surgery. This is what we try to do with cutting out like the whole section of lung, which I'm going to talk about in more detail. But that really, I just wanted to sort of cover that as sort of the opening thing to clarify that the principle with why surgery helps in some cancers is that you can get around it. You can get what's called a margin. You can get clear of it. And the body part it's in, the kind of cancer it is, and the location of where it is means that you can do that. And that's one of the problems with mesothelioma. It isn't possible to sort of just cut out the whole chunk of chest with ribs and muscles and everything else. It's not compatible. As we say, a very medical thing to say, not compatible with life, which means you can't live with half your chest cut out. That's unfortunate for people who do have an advanced mesothelioma. There's other way to think about it is if you have a mole on your skin, you're not going to cut out around the edges of the mole. You're going to draw a diamond around the outside of it and cut out around that diamond around the outside because you want to make sure that you get any microscopic roots of the mole. Okay, and the problem is we can't do that with meso. So we're going to talk, but that doesn't mean that surgery doesn't have a role. So we'll talk about a few things. It does mean that surgery is often involved in the actual diagnosis, actually getting tissue, for getting biopsies, to actually then work out to say definitively that what we're dealing with is mesothelioma. And then dealing with one of the other consequences, what mesothelioma does, which is to create what's called a pleural effusion. So the lung fills the whole chest. Our ribs are like a big barrel, and the lung is like a sponge that fills the whole barrel. You can have space between the ribs and the lung, and that can fill up with fluid, and that's what we call an effusion. So if you look at the X-ray on this side, so this side over here, this is the heart in the middle, and then you've got all the black area here is lung full of air. Okay, air doesn't block X-rays, so you get X-rays going right through and exposing the film. On this side here, there's a big white patch here because there's something which is really denser than air, which is blocking all the X-rays, and this is what fluid here. So over here, you should be able to see the diaphragm, but you can't see the diaphragm. You should be able to see black space full of air because you should be able to see your lung, and you can't because it's full of fluid. And this is what we call an effusion. It can be a lot more than that. You can have a whole chest full of fluid. And this will definitely make you feel short of breath. And this is an example of Simon's point that it's the mechanical complication of not being able to actually take a breath in, not being able to expand your lungs that makes you feel short of breath. It's not the amount of oxygen level. Because you can actually have this amount of fluid in your lung and actually still have normal oxygen levels because the other side of the lung is actually still doing enough work. So your SATs at your finger might actually not too bad, might be in their low 90s, but you still have a whole chest full of fluid. And this is actually often how mesothelioma is first picked up because it's growing on the inside of the ribs and then it starts making fluid, okay? And so the fluid then fills up the whole barrel of the chest and compresses the lung. So often what we're doing as surgeons is actually helping to treat this. So when we're doing that, we're often then we're often doing one procedure where we actually are taking samples, sending it off to the lab to actually get the diagnosis of mesothelioma made, and then treating the effusion as well. So this is often what it looks like on the inside. So we put a camera in, you can sort of get the impression that that what we're looking at has lines to it. There's sort of the section that's running along here. And then there's another sort of section. You get the impression that there are lines running that way, and that's because that's the underlying ribs, and then the muscle, ribs, muscle, ribs, muscle. On the inside of that, there is a thin layer of cells called the mesothelium, which is it's the pleura, which is a mesothelial surface. And then we have this soft fleshy tissue, which is growing abnormally. So instead of the pleura being almost like just a thin single layer of cells, it's now thick and fleshy, and this is what mesothelioma often looks like. That's when you hear sarcomatoid. Sarcomatoid refers to it being kind of like a fleshy kind of thing, a fleshy kind of growth. Oma is sort of is a word for tumor. So so the pleura is a mesothelial surface, and if you have a tumor of that, you have a mesothelioma. And so that's why you can actually get mesotheliomas in other parts of the body apart from just the chest, because there are mesothelial surfaces elsewhere. So I've seen a mesothelium around the heart, and you can have mesothelioma around the heart, and you can have a mesothelioma in the abdomen. Okay? But most of the time, because asbestos is usually breathed in, it migrates to the edges of the lung and then migrates out to the pleural surface. you end up with a mesothelioma of the lung as the most common mesothelioma we see from asbestos. So, with palliative surgery, palliative refers to the idea of making it at the end of life comfortable. It doesn't mean that there isn't a role. Sometimes surgery is about making life longer, about clearing disease out and being a cure. And sometimes surgery is about making you feel better in what time you have left. So it's about quality of life. And that's what palliative surgery is. And that's often what we think about. So sometimes we're going to talk about this a bit more detail. Pleurectomy, trying to cut away the pleura, that grows over the lung, which is decortication, and pleuropneumonectomy. So we'll go through this in a bit more detail. VATS. So video-assisted thoracoscopic surgery is what VATS stands for, if you've heard of this. So this is a revolution created by the invention of long telescopes that we could put inside the chest. And so the fact that we can actually see inside the chest without having to make a big cut and actually look with the naked eye is a big thing. It means that we can do keyhole procedures on the chest. So telescopes are about 5 millimeters in size, up to 10 millimeters. They actually have an angle on the end of them, so they're a bit like a periscope. You can look around corners, so they have a 30-degree or 45-degree angle on the end. So when we put the telescopes in, we connect them to a TV screen, and we actually just look at the TV screen as you move the scope around inside the chest. And you can actually, with the angle, you can actually kind of turn the corners and look around the corners. You're not just looking straight ahead. They're long, thin metal pipes with fiber optics in them. And that really, it's something that came about in the early 90s that really then took off, really changed what we can offer people, because we can do minimally invasive things inside the chest, because we can, with a 5 millimeter scope, it means you just need a 5 millimeter hole. Scopes are sometimes 10 centimeters or 10 millimeters or a bit bigger. But this is usually what we're doing to actually, when we're trying to drain a fluid, to get biopsies, we often do it this way with the VATS. Generally takes about 45 minutes to do. If we're doing a VATS procedure, and the hospital stays somewhere between 2 and 4 days. And this is kind of what it looks like. We've made a hole in the chest, about 5 to 10 millimeters, put a camera in, and then we actually can make another hole, we can put another instrument in. So we have long instruments that we can work. It's a bit like working with really, really long chopsticks sometimes. This gives us the ability to actually then look at the lung, get small samples. You can see things like, this highlights my point about the accuracy of CT scans, that these little fine dots here, you can see with the naked eye and you can see with a scope, but you wouldn't be able to see them on a CT scan because these things are less than a millimeter in size, but you wouldn't be able to see that on a scan. And that's part of the problem with when you look at a scan, trying to work out how, with the full extent of the cancer, of where it is that sometimes if it's got microscopic deposits, you won't be able to actually see them on the scan. So what we do with, just to go back here, is that what we do to deal with the fluid, to deal with the effusion, is that to do a VATS procedure for a pleural effusion for mesothelioma is to do a general anesthetic. We put you on your side. We put a breathing tube in where we breathe for one lung or the other, and we can turn off one lung. We then put the cameras in. We then suck all the fluid out, take biopsies, and then spray talc inside the chest. And you get a medical talcum powder that you spray inside the chest, and that causes an inflammation between the ribs and the lung, and that causes scar tissue to form. And then if you have the lung scarred to the inside of the ribs, then that can't fill up with fluid. So if you think about the barrel and the sponge, it's like gluing the sponge to the inside of the barrel. You can't fill that up with fluid anymore, and that stops the fluid from coming back. So even if the mesothelioma tries to make fluid, it doesn't then have anywhere for the fluid to go. Okay, so the lung can't collapse, the lung stays up. So it helps with that mechanical process of fluid pressing on the lung, makes you feel short of breath. So we stop that from happening by not giving the fluid anywhere. The fluid can't fill up that space. There's evidence that chemotherapy, which is drugs derived from actually have platinum in them, so they're actually quite fancy drugs made from platinum, does actually improve survival benefits. So if you have mesothelioma and you get some chemotherapy, you will live longer than if you don't have the chemotherapy in general. Every chemotherapy, everything we do in medicine has upsides and downsides. Even like your question about x-rays before, if you find something you didn't want to find, you can have a negative effect from something as simple as an x-ray. And so chemotherapy has side effects, so you have to be able to put up with having the chemotherapy, and you will. But by and large, we know that if you have the chemotherapy, you can put up with it, then you will generally live longer than if you don't have the chemotherapy. The immunotherapy, there are things that are being trialed at the moment, like trying to immunize people or give people a vaccine against mesothelial. Mesothelioma makes certain chemicals and makes certain proteins, and if we can give your body a reaction to that particular protein, it will then attack it by itself, and it can mop up every single spot where that chemical is. And if that chemical is only made by mesothelioma, then the body will attack it itself. And that's what vaccination therapy is about, and immunotherapy is a similar sort of concept to that as well. We were discussing this before, that getting the diagnosis 100% right, which is important for a compensation claim. Usually, and when I teach trainees, I always teach that we should you get a biopsy that goes all the way through the entire level of the mesothelioma into the chest wall to actually prove that there's invasion in the chest wall, to give you a 100% accuracy of mesothelioma. But we're getting more and more accurate with diagnosing things from fluid alone, but that's still evolving. If just sucking out the fluid and then getting an accurate diagnosis of mesothelioma is still part of the discussion about and being proven in compensation cases. So we've certainly tried lots of different things, and we see a range of mesothelioma. People sometimes, as you'll be aware, will show up with completely no warning signs and show up with a very advanced levels of mesothelioma. And then sometimes people will show up with sort of mesothelioma in a small amount, and we've certainly tried different levels of surgery, cutting out just the mesothelioma, cutting out the rib it's next to, cutting out the lung that it's next to, and everything else. So what we're going to talk about is extrapleural pneumonectomy. So this is it's an operation in which you take out if you think of the chest as that barrel with the sponge on the inside, it's like making a cut in the barrel and then cleaning out everything that's inside it. So you basically scrape the entire surface of all of the ribs and take out the entire lung that's in that side of the chest. And that means that the lung is next to the heart. You have to take the sac that covers the surface around the heart. It goes onto the diaphragm, so then you cut out the diaphragm as well. You can't cut out the ribs, the entire rib cage. So what you do is then basically scrape and clean all of the ribs on that side. So you take out everything that covers the inside of the surface of the ribs, and all the way down, to the lung as well, and then take out the entire lung. So you can imagine that's a very, very big operation to go through. And so one of the problems is, and this is the downside, we try to be aggressive, try to get every little bit of cancer out. But if you do an operation that's so big that you can't survive it, then that doesn't do you any good. And this is what's been found when we've done scientific studies about this, where we've put people into two different groups and said, okay, well, you guys have surgery and you guys have chemotherapy only, that those who've had the surgery, there's a certain percentage of people who don't get through the operation at all. They don't survive the operation. And then there are people who survive the operation, but they don't survive the next month or the next 6 weeks or the next couple of months. And so when you get down to the track in these 6 months or a year, that both groups are actually the same proportion of people are alive in both groups. So we can put you through a really big operation, but then if you don't survive it, you've gambled everything or lost everything. And that's the problem with surgery at the moment with chemotherapy, with extrapleural pneumonectomy. There will always be, in every rule, there's always an exception that proves the rule. There will always be someone who is young enough and fit enough, they can survive an extrapleural pneumonectomy, and they've got disease that happens to be in one spot that we can actually get around. And for that person, an extrapleural pneumonectomy might actually help that particular person. But when we take most people who have mesothelioma, most people will not be able to, number one, put up with the surgery, and number two, the mesothelioma will actually we can't actually clear it, just can't get around the outside of it. If you use that barrel analogy, it's like if you've got the barrel and clean the entire barrel out, it's like the mesothelioma has gotten between the slats of the barrel and has leaked out the bottom of the barrel already. So even if you clean it out, it's already gotten beyond the chest. Surgeons, we become surgeons because we like operating, and most of us like doing really big operations, and so we like the idea of, we really would like extrapleural pneumonectomy to be a really good thing for people, because it would mean that we get to do big operations on people and they get better. And this is where this comes in. That this is the Mars trial. This is the trial that showed this, and this is that in hospitals in the UK with doctors who were very keen on doing these big operations. When they tried to do this on large numbers of people, it didn't help people one way or the other. That if you had surgery, you end up being just as sick as people who did not have surgery, but you've gone through a big operation. The other thing we've done is tried to think, well, what about just stripping the pleura off, just trying to leave the lung in there but take off the pleura, compared to just spraying that talcum powder inside the chest, and that doesn't really change things. Again, it's more that you end up, the more aggressive you are, the more complications you have. So we swap you from having the fluid from mesothelioma to then having complications from the surgery. So that doesn't necessarily change things a lot as well. So transplantation, and why can't we just cut out the lung, clean everything out, put a new lung in, make you feel better? The problem with that is, apart from everything we've already talked about, is that if you put a new lung in, you then have to have chemotherapy, which then immunotherapy, the immunosuppression. And if you put a new lung in someone who's had cancer, and then you turn their immune system off, then any loose piece of cancer that's away is completely unrestricted, and it just takes over. And so then you would go through a big operation, have a transplant, and then end up with mesothelioma then growing back, and that's you're back to square one. There are reports of people then having lung transplants or having transplants for other reasons and getting mesothelioma because of the immunosuppression. And we've certainly had, this is Morgan's experience at Prince Charles, transplant patients who then end up with lung cancers in their transplants. So it isn't a cure as well, but it's a reasonable question to ask. I might just leave that. I won't go on to here in the pleural parks. We've had the question about, do they cause pain? And I'd just like you to, so Morgan's, I haven't personally taken out a pleural plaque for pain control, but Morgan has. And so there might be a little bit of surgical bias to say that it did help, but it's definitely a sort of a case by case, and try every other cause. Try and find a solution every other way. And if there's still pain from the pleural plaque, then that you think might be related, and it is something you can cut out, that is something that you could try. But the thing is, you could possibly go through surgery, come out the other side, and still have the pain. Surgery for pain in general is a very unrewarding experience, because surgery itself is painful. All right. This is what plaques look like on the inside. So there's sort of plates. This, in contrast to that first slide where it looks soft and fleshy, plaques look like this. They're hard, rocky sort of plates of plaque. Okay, just I think that's time there. So I'll ask if there's any questions.
Just a question over here, Dr. Cole. Just one moment. Jane?
I don't know whether you could answer this, but where are we on research for about stem cells for lung disease?
That isn't quite in my area, but in general, stem cells are, when we talk at the beginning about, we all start off as before we're even born, we start off as one cell that grows into multiple. That's what stem cells are. Stem cells are those cells that then grow into everything else. And so usually we're looking at stem cells in terms of regenerating healthy tissue. They have to also grow the structure. So the lung is a very structured organ. It has airways, and so you've got multiple. You have to grow the structure as well as the cells, and that's the challenge for stem cell research in the lung.
Chris, quick question.
Doctor, why are pleural plaques, pleurodesis, not always successful?
So it's what we're not doing what we're doing inside the chest is actually spraying the talc across the entire surface and then waiting for the body to create the reaction. So you spray the talc everywhere, and then you want the reaction to occur at the same time that the body is still making fluid inside the chest. So you have this process of the lung has to stick to the inside of the ribs and form scar tissue across it, at the same time that the pleura is making fluid and washing the lung away. So it will stick in some locations and then it doesn't stick in others because it's sort of the balance between the fluid is pushing the lung away as we're trying to get the lung to stick.
Question up the back, Doctor.
Patients that have pleurodesis, sometimes after that they do have pain from the actual surgery, but also they feel like it's nerve pain. Is nerves involved when you're having a pleurodesis?
Yeah, so as our spinal column runs down our spine, it gives off a nerve at every spinal body and one nerve at every rib. So as you go through, and we don't go through the ribs, we go through the spaces between the ribs, the muscle between the ribs. And sometimes in spaces they can be only 1 centimeter in the muscle space is only maybe a centimeter or so, and you're putting a port through which is can be up to 12 millimeters in size, and so that can press on that nerve because you have one rib. Every rib has one nerve, and so that can press on that particular nerve.
Quick question.
Just a question on pleural plaques. To what extent, like if you've got multiple pleural plaques, does that stiffen the walls of your lungs more than if you just had a few?
Yeah, and that's in Simon's talk, he had some very good CT scans of that in which you've got multiple plaques around the outside. We all have to expand. If you want to take a big breath in, you're going to expand your lungs by 1.5 liters, 2 liters. And then if you have multiple plaques that are restricting the ability to actually move your chest, then you won't be able to take that big breath in.
Quick question from me, Doctor, and it's a little bit outside your area of expertise, I know, being a surgeon.
Sure.
But one of the things I've seen, I have a client with mesothelioma who's had chemotherapy, and he sent me in a CT scan report, and there's been, dramatic reduction in his tumor size. But then some other clients who have chemotherapy don't seem to have the same result.
Yeah.
You mentioned immunotherapy, Keytruda. I was speaking to one of the members today. He's had 17 doses of Keytruda as an immunotherapy drug, and he seems to be doing extremely well. In fact, he looks better today than he did 6 months ago. But others on Keytruda don't seem to have the same positive response.
Yeah.
Why is that? Why? It's the same disease, it's the same therapy.
Yeah.
Why is there such variability in response?
So it's because it is one disease that acts in the same way in general, but everyone's cancer has slightly different genetic mutations. So if you think about it like a tree, and then branches. And so you'll have one genetic mutation that sort of sets up the cancer, and then you'll get more and more genetic mutations just become like all the branches. And the chemotherapy and the immunotherapy attacks at different levels. Because everyone's cancer is slightly different, that variation in the genetic mutations is different, the response will be different. If your mutations are further down closer to the base of the tree, they're more important mutations, and then the treatment you're given attacks that particular mutation, you'll have a very, very good response. If it attacks like a main branch of it, you'll have a good response. And that's what often you see is that you give people treatment for a while, they'll have a really good response. And what's happening is that if you use that tree analogy, one of the big branches has been cut off. And that all the genetic mutations past there are no longer functioning. But then what happens is that the genetic mutations on like the other side of the tree start to then mature and start to grow out, and then the cancer starts to take off again. And that's why you can have treatment response for a while, and then mutations accumulate elsewhere that aren't being attacked by the treatment, and the cancer then regresses, relapses.
Thank you. I think we have a question up the front.
Is pleural effusion always linked to mesothelioma, or can it be benign?
Yeah, it can be benign, yeah. And exactly, there is a benign, there's benign asbestos-related pleural effusion, BAPE, exactly. And it can be that you've got plaques and asbestos exposure and end up with effusions. And that means that sometimes there is a situation where you have an effusion, you've got plaques, you've got an asbestos exposure, and the first thing we think is that it's mesothelioma. Then you go through having a VATS procedure, you do get a biopsy, and you get talc pleurodesis, and there's no mesothelioma found. because it'll be a benign asbestos-related pleural effusion, which is the upside, which is good news at a dark time. Yeah.
Helen?
When my husband died 9 years ago, we were told there was absolutely no chemotherapy. He had very successful surgery and his lung drained for about 3 weeks. But we had a very good 12 months, no problem at all with breathing. It was just pain relief, which was much easier to relieve pain than it is to relieve breathing, because I'm a trained nurse. But there was no chemotherapy then. So I gather there is some now.
It depends on the type of there is a subtype of mesothelioma, and it does depend on what you can put up with as well. But there is some chemotherapy now. Yeah.
Thank you.
Oh, Natalie?
I just wanted to ask if different types of mesothelioma cause different types of pain levels, because I've got some members that I support, and some members with mesothelioma suffer no pain at all, yet other members are actually in quite a lot of pain.
As far as I know, there's no link between a specific type. My theory would be whether it's involving the nerves or not. It's where it's locally grown. I think that's where it's invading, I think would be my theory.
I think we have time for one more question.
Hi, I just wanted to ask you about the managing after the surgery and managing the pain or pain control.
Yeah.
Do you think the medicinal cannabis would help?
Oh, I don't have any experience or knowledge of medical marijuana, so I can't answer that particular question. Yeah.
And one final question from Trevor.
Dr. Cole, we run quite a number of community morning teas throughout Queensland, and one of the questions we've been asked reasonably consistently is in relation to the Johnson & Johnson issue over in the States, where people are getting, allegedly getting an asbestos-related disease from the talc powder.
Yeah.
One of the questions that asked is when the surgeons go in and use the medical talc, what's the deal, because it's got asbestos fibres in it, and we know that talc is associated with asbestos mining. So can you just make comment on that, please?
Yeah, that's an interesting one. So in the situation where you have a mesothelioma, you've got an asbestos-related effusion, treating you now is sort of the priority for that. And we know that there is a lag time, as we know, with asbestos disease. So if you have exposure, you're going to need a couple of decades worth of lag time. So if we're not looking at a decades-long horizon, then giving a small amount of exposure now is not going to change that. It is relevant in that there is a condition that affects young people, in which surgeons often use talc, and that is where you get a spontaneous pneumothorax. For some reason, very tall, thin, particularly young men tend to pop their lungs and collapse their lungs when they're around the age of 20. And getting the lung to stick up at that stage is often, some surgeons will use talc at that stage. There hasn't been any study to show that doing that has resulted in rates of mesothelioma at 20 or 30 or 40 years down the path. But some surgeons will avoid using talc. I don't use talc in that situation because I don't want to give that person that possible risk of exposure. Yeah.
Just one other question. There was a case in South Australia recently, and I can mention his name because it was reported that Mr. Werfel had mesothelioma of the testicles, which that'd have to be the rarest of rare. And I'm just wondering, how does that occur if it's generally a lung-related disease?
Yeah, so it's about the fact that, as I say, mesothelial cells is a general description of cells in the body, that if you have a particular lining, it's called a mesothelium. And if you can get asbestos exposure into that area, it can, in theory, form a mesothelioma. It's a long way from having breathed it in. Yeah.
Well, thank you very much, Dr. Cole, for that very informative talk, and really appreciate you coming out. I just asked Phil to pass on a small token of our appreciation for coming out today and giving up your valuable time. Thank you very much.
Thanks very much.